Good morning, everyone. So when I was asked to present these trials, I had no idea how to look for these trials. So the first thing I did was go to clinicaltrials.gov. You type in coronary artery disease, there are like 9,000 studies that come up. And then if you type myocardial infarction, FFR, left main, there are hundreds of studies. So there's no way I could have found out the anticipated trials. So what I did was I tried to categorize these into different headings. So for stable coronary artery disease, I think the most anticipated trial is the Ischemia trial, which will be later presented at AHA this year. In terms of physiology and imaging, FAME3 will be probably presented later this year, and Illumin 4 in the next 1 or 2 years. In terms of atherectomy or plaque modification, intravascular lithotripsy with DISRUPT-3, and ECLIPSE study with orbital atherectomy. In terms of pharmacology, as Dr. Pilakis already mentioned, TWILIGHT will be presented hopefully at TCT, and then short DAPT with Science 90 trial. In terms of acute coronary syndrome, specifically with STEMI, the complete trial will be presented at ESC, and there are 2 other trials, full revasc and multi-stars AMI in the pipeline. And then in terms of stent platforms, I think a few biodissolvable scaffold studies will be presented too. So starting with the ischemia trial, so the hypothesis here is that coronary revascularization, when added to optimal medical therapy, improves prognosis in patients with stable ischemic disease at increased risk of cardiovascular events due to moderate or severe ischemia. Now, this trial has been ongoing since 2011, and it's an NIH-sponsored trial. The initial enrollment was supposed to be 8,000 patients, but due to slow enrollment, I think only 5,179 patients were enrolled. Everybody had moderate to severe ischemia by non-invasive testing. They underwent CT scan to rule out left main disease, and then were randomized to optimal medical therapy versus invasive strategy with optimal medical therapy plus angiogram and PCI with second-generation drug-eluting stents or bypass as appropriate. Now, the primary endpoint has been a matter of debate for recently because it was changed from a hard outcome of cardiovascular death and MI to a composite endpoint of cardiovascular death, MI, cardiac arrest, hospitalization for unstable angina or heart failure. And the secondary endpoints are cardiovascular death or MI. So the major exclusion criteria were low EF, worsening angina, or ACS within the last 12 years. The stress testing was done in majority of the patients with imaging with either nuclear, echo, or CMR, but in a small subset of patients, about 1,270 patients, just underwent an exercise treadmill test, but they had very strict criteria to define ischemia on that. So this is the timeline, how the changes in the primary endpoint happened. Initially, it was supposed to be a 5-component endpoint, then was changed to 2-component, and then was changed back to 5-component endpoint in June of 2017 due to slow enrollment. So coming to FAME3, FAME3 hypothesis is that FFR guided PCI using second-generation resolute DES in patients with multivessel disease will result in similar outcomes to coronary artery bypass grafting. So it's a multi-center, worldwide prospective randomized trial with a non-inferiority design with 1,500 patients from 50 sites with 2-year enrollment and up to 5-year follow-up. The major primary endpoint is one-year rate of death, MI, stroke, and revascularization, and secondary endpoint is 3-year rate of death, MI, and stroke. This is the trial design, so all comers with 3-vessel coronary artery disease, the left main were excluded, and the heart team identified whether the lesions were suitable for PCI or bypass, and then the patients were randomized to either FFR-guided PCI or coronary artery bypass grafting. The threshold for FFR was less than 0.80, and then the follow-up is 1 year for MACE and then 3 years for death, MI, or stroke. So now coming to ECLIPSE trial. So this is a trial with 1-to-1 randomization of orbital atherectomy versus conventional angioplasty prior to implantation of second-generation drug-eluting stent in patients with severe calcific coronary stenosis. And the primary, it's a 2,000-patient study at 60 sites, and the primary endpoint is post-PCI in-stent MSA and 1-year target vessel failure. And the secondary endpoint is procedural success defined as stent deployed with residual stenosis of less than 20% and no major complications. On the same pathway, there's a DISRUPT-3 study which began enrollment earlier this year with intravascular lithotripsy. And it's a study of de novo heavily calcified coronary arteries with intravascular lithotripsy followed by stenting in stable or unstable angina with a vessel diameter of 2.5 to 4 millimeter and lesion length of less than 40. The study aims to enroll about 392 patients, and their primary safety endpoint is MACE at 30 days, and primary effectiveness endpoint is procedural success, defined as residual stenosis less than 50% without in-hospital MACE. And there's an OCT sub-study of about 100 patients as well. Now coming to pharmacology, this is a Science 90 trial, which is looking at DAPT for 3 months and then aspirin monotherapy for up to 12 months, whether that reduces all-cause death or MI in patients with high bleeding risk. So it's a single-arm, prospective, open-label, non-randomized trial, and they're going to compare that to a propensity-adjusted historical cohort. It has two, there's another program with the Science DAPT, which is a Science 28 program, which began enrollment as well recently. Coming to the TWILIGHT trial, trying to find what's the optimal DAPT duration and strategy for post-PCI patients. This is ticagrelor plus aspirin for 3 months in post-PCI high-risk patients who were randomized to ticagrelor plus aspirin or ticagrelor plus placebo after 3 months up to 12 months and looking at bleeding and ischemic outcomes. Similar study was presented by Dr. Bilakis, global leaders, so we'll see if this study shows the same result. Now coming to COMPLETE trial, this is the trial looking at whether patients with STEMI who present with multivessel coronary artery disease, whether doing culprit PCI and staging with complete revascularization versus just doing culprit PCI revascularization, is there any difference between the cardiovascular death or MI between those cohorts? So anybody with STEMI undergoes PCI for the culprit lesion and have to have a stenosis of more than 70% or more than 50% with the positive FFR prior to randomization. The last trial is Illumin 4, which probably won't be done for another year or so because of slow enrollment, but it's another imaging trial looking at superiority of OCT compared to conventional angiography in a high-risk clinical characteristic lesions and looking at angiographic results and cardiovascular outcomes. So in summary, these are the trials I presented, and a lot of the trials are anticipated this year, but a lot of emphasis is on aggressive optimal medical therapy, lowering the duration of DAPT, and incorporating more physiology or imaging into daily practice. Okay.